Hi, Maddie. Hi, Robin.
Hi.
Hi.
Hey, Maddie. We're ready if you want to go ahead and kick us off.
All right. Hello, everyone. Welcome to Shattered, the moral crisis in American healthcare. And thanks to the media also who've shown up. I'm Dr. Madeline Jacobs. I'm on the board of the Colorado Foundation for Universal Healthcare and chair of the Medical Professionals for Universal Healthcare under its auspices. Joining me on our panel are nurse practitioners Robin Mills and Mary Pat DeWald and doctors Lori Costello and Jonathan Ward. So we will open with a 6-minute video from the New York Times about moral injury due to corporate greed. And following that, each of us will talk for about 3 minutes, each of us on the panel, that is, and tell what our experience of this has been. And then we'll devote the rest of our time to answering your questions and discussion. We are recording the event and it's being streamed live on Facebook. So you've been muted just to reduce background noise, but we do value your input. So please type your questions and comments in the chat. Thank you to Sarah Wright and Bill Semple from the Foundation for your help on this event. So we'll go to the video now.
You know, they call you an asshole.
Been called a bitch 1,000 times. A knocked up whore. Get the F out of this effing room, you effing N-word. I've been bitten, choked, punched in the mouth. I had a guy try to kick me in my stomach while I was pregnant.
That poor nurse at your bedside has probably been through hell with the last 10 or 15 hours. And then you come in demanding ESPN. Are you kidding me?
And it's like, well, yeah, I got punched in the head tonight. And any other job would be like, what are you talking about? 2 years into the pandemic, COVID is surging. America's frontline nurses are overworked, burnt out, and quitting in droves.
The H is for hospital, not hotel. Treat me with respect.
As Omicron pushes hospitals to the brink, America is facing a national nursing shortage. But it's not patient abuse that is ultimately driving the crisis. I literally don't even want to be a nurse anymore. Like, this shit sucks. It's not emotional trauma. I hate my job, and I don't want to go back. It's not even COVID. I cannot do this anymore. The biggest force that's driving nurses away? Greedy hospitals. I could no longer work in critical care under the conditions I was being forced to work under with poor staffing. And that's when I left. To maximize profits, American hospitals have been intentionally understaffing nurses for decades, long before the pandemic. What the hospital industry doesn't want you to know is that there's never been more licensed nurses in America. Hospitals just aren't hiring. There's not a shortage of nurses. There's just a shortage of nurses willing to work under those conditions. If you don't have enough nurses, patients will die. They will become sicker and they will die. If you're in the hospital, your chances of dying go up by 7% for every additional patient your nurse has to care for.
If you push me past my limit, past my capacity of being able to multitask, something's going to get missed. And when I say something, I'm talking about your mother. I'm talking about your father. I'm talking about your husband and your wife. There have been many instances where patients that die that shouldn't have died. I know that unequivocally. Families, they feel like you've done the best job that you can. And the reality is we're not. I could not get into her room for over 2 hours. When I did get into the room, she had tears in her eyes. She was crying and holding on to me. And when I looked in her bed, she was soiled in urine. I felt like I did a bad job. I felt less than the nurse that I know I am. And I started to cry all the way home. Can I make another shift? Can I do this again tomorrow, get in my car and drive here and do this again? The system was already broken. COVID has just made it
way worse.
In one 12-hour shift, we had 6 patients die under the age of 50. And as quickly as they got those beds cleaned, there was more patients there.
A patient grabbed my hand and he begged me to not let him die. Sorry. And I told him that we would do everything we could within our power. And I felt like I was ready to fall apart, but I couldn't because the patient in the next room needed me. To understand how the situation became so desperate, you have to remember that hospitals are just like any other business. Staffing takes up about half the budget, so a smaller workforce means bigger profits. Hospitals use this type of what they call flex staffing, so they flex for just the bare minimum at that hour of the day. And then 3 hours goes by, there's many more patients, and then it's, well, you have this many nurses, you have to just make do.
The most annoying thing that was ever said to me in my career by an administrator was, we know you guys need nurses, but it's not in the budget.
The situation is dire. More than 40% of nurses are thinking of leaving the profession.
I hope to be able to leave the bedside within this year.
I don't know how long I can do this. Physically, mentally, emotionally, I will never work in a hospital again. I will never subject myself to that sort of frustration, and I will never.
Sorry, someone is not muted and there's a lot of people muted.
Sarah,
Yeah,
as the host, you can mute.
mute all, yeah, I should do that. Thank you for that reminder in the moment. All right, we'll go back to the video now. Thanks for your patience.
The situation is dire. More than 40% of nurses are thinking of leaving the profession.
I hope to be able to leave the bedside within this year.
I don't know how long I can do this. Physically, mentally, emotionally.
I will never work in a hospital setting again. I will never subject myself to that sort of frustration, and I will never be part of what's being done to patients in a hospital that way. Focusing on pandemic burnout lets hospitals off the hook. We should be talking about better nurse-to-patient ratios, which would save lives.
There really needs to be a systemic change from a legislative standpoint.
Why wouldn't you limit the number of patients, human lives that nurses hold in their hands every day to a certain amount that's safe? The solution is simple. Pass common sense laws that limit the number of patients for each nurse. Pennsylvania and Illinois both have bills pending that would do just that. But a similar law in Massachusetts failed to pass in 2018, thanks in part to a $25 million campaign by the hospital lobby.
It puts government in charge of deciding how nurses care for patients with the same rigid staffing ratios at every hospital in our state. A one-size-fits-all attempt to override the professional judgment of nurses.
The problem with these ads, they're misleading. Just look at California, where a bill like this did pass. The result, more nurses hired, more nurses staying in their jobs, and better patient outcomes. This is a national emergency, but one created by the hospital industry, not the pandemic. We need to save lives, not profits.
It's my biggest fear, is to miss something that hurts someone. Because I'm not there to hurt, I'm there to help. And we need more help.
I'm going to go ahead and try my video. I have rural internet, so Sarah, if I'm really delayed, let me know so I can turn off my video. I'm always moved by that video every time I see it, as it reflects my experience in this healthcare system. I practiced family medicine in rural Colorado for 30 years, and much of my time was spent struggling to get basic care for my patients. Hours were spent fighting for diagnostic and therapeutic treatment for people. I felt like I was continuously banging my head against a barricade, determined to block the needs of my patients. Some examples: I had a lovely long-term patient who often invited my staff over for lunch. He became a double leg amputee due to peripheral artery disease. He had a cheap manual chair, literally held together with one screw and duct tape. Despite hours of trying to get him a decent wheelchair, we failed. I had asthmatics who ended up on ventilators because they couldn't afford their medication. I sat with cancer patients who have just found out their diagnosis and trying to decide whether to seek treatment or threaten their families with medical debt and die prematurely. This is moral injury and distress. The definition of moral injury is when a person knows the right things to do, but is powerless to do it. The emotional state that arises is called moral distress. It is not simply burnout, which does not reflect the moral component caused by a broken system whose goal is profit, not healing. Moral injury and distress are having a huge negative impact on our healthcare system. A 2018 study of the American Psychiatric Association showed that physicians have the highest suicide rate of any profession, including combat veterans. Healthcare providers are leaving their professions in huge numbers across the board. This existed long before COVID. COVID has just exacerbated it. The root of moral injury is the toxic soup of our healthcare system that sees the purpose of a healthcare system as profit for the few, not the health of all. That sees healthcare workers and patients as assets and commodities to be used up and thrown away, not human beings. When I first began as a doctor, our goal was the health of our patients. And I loved being a doctor and took care of multiple generations of patients from cradle to grave. But the system has been corrupted and twisted in the last few decades. This toxic system has blamed moral injury on the people suffering from it, saying they need to be, quote, moral resilient, unquote. The same people who have shown they are some of the most resilient people on the planet through the trauma of the pandemic. The good news is that there are solutions which have been implemented around the globe. Here in Colorado, such propositions have been put forward, but unfortunately are often met with silence. Perhaps during our question and answer section, we can share some of those solutions. And with that, I'd like to pass this along to Robin. Thank you.
Hello, thanks for being here and having interest in this important topic. I work currently as a family nurse practitioner in family medicine. My entry into healthcare was when I started studying massage in the early 2000s. And I got into this line of work to help people feel better and live healthier lives. Unfortunately, this mission has only become more challenging over the years because our health system does not promote health. While it can be great at treating trauma and many life-threatening illnesses, it can help people stay alive, but it doesn't guarantee or often prioritize the quality of life that will be lived after that life is saved. Instead, we have a disease care system focusing on either utilizing expensive procedures and medications that benefit hospital systems and pharmaceutical companies, or denying care to benefit the insurance companies. There's a focus on numbers instead of patients as individuals and their social determinants of health. As a family medicine provider, where at least 80% of what brings people into the office can be prevented and treated with lifestyle modifications, we don't have the time or resources, including adequate reimbursement, to fully address lifestyle as a treatment. I know that providing quality preventive care is providing the best primary care, yet our current sick care system makes it unnecessarily difficult as healthcare providers to prioritize this type of care. Additionally, there are multiple social inequities that make it challenging for patients to care for their own health. And day after day, I see patients struggling to have access to a grocery store or knowledge about how to prepare healthy foods. They can't walk in their neighborhoods, or they don't have access to an alternative way to be physically active, like a pool. They have to share housing due to high costs of living, meaning a quiet and comfortable place to sleep can be a huge challenge. There's also ongoing interpersonal conflict, childhood and ongoing trauma, which make behavior change a challenge. Ideally, I'd have an hour with patients to address all of these contributing factors, but instead I have maybe 15 minutes because it's the quantity of patients, not the quality of care, that means increased reimbursement to keep our doors open. Patients don't always have the time either. They're caring for children and family members while working multiple jobs. They have transportation challenges. So then medications become this fix, the way to improve their health, and it can seem easy for a patient to comply with taking medications, but unfortunately, that doesn't always help them feel better, unlike a lifestyle modification. And in my opinion and experience is why non-compliance has become more frequent. Additionally, medications that are prescribed are often not covered by insurance, or an alternative is required, even though it's not the best medication for their diagnosis or even following the most up-to-date guidelines. So then myself and my colleagues spend hours on the phone haggling with insurance companies to get these vital treatments, supplies, procedures covered. There's just too much inadequate treatment. And so then ultimately, we end up with expensive procedures like dialysis, amputations, stents, and surgeries that become this definitive treatment. If only we could simply divert money and time to prevention, having a single payer universal healthcare system would be a great way to do this. We could save billions and also have a healthier, more engaged citizenry with improved social justice. Again, I got into this work to help people, and unfortunately it becomes just more and more difficult as our system becomes more and more privatized and shattered into disjointed pieces. Additionally, as healthcare providers, we're overburdened, consistently asked to do more with the same or less time and resources, often knowing what should be done without the resources or ability to do it. The definition of moral distress. Now I'll turn it over to Lori.
Thanks, Robin. My name is Lori Costello. I grew up on the beach in Southern California and 40 years ago found myself in medical school at UC Davis. I didn't know any doctors or what practicing medicine would be like, but I loved it from the very beginning. During each clinical rotation, I decided that I would go into that particular specialty. Finally, I chose family medicine so I could do it all. There was a worsening shortage of primary care physicians even back then, and few people knew that family medicine is a specialty. We managed more than 90% of our patients' problems from cradle to grave, both inpatient and outpatient care. As a medical student, I wanted to bring healthcare to what we used to call the third world, and I spent the last 3 months of medical school in Nepal, where poverty and preventable illness were rampant and affected children disproportionately. Now we refer to places like Nepal as the developing world or under-resourced areas. Sadly, a huge portion of the United States is under-resourced for healthcare. It has been for decades. We rank rock bottom of 11 developed countries for quality and efficiency of our healthcare system. We spend at least twice what other countries spend. The World Health Organization ranks us 37th in the world, and all this has happened during my career. The essential element in healthcare is the doctor-patient relationship. One of my first clinic patients as an intern in Spokane, Washington, was a middle-aged woman smoker with emphysema, to whom I sheepishly recommended smoking cessation. Months later, after she had quit, I asked her why. Because you told me to. I was profoundly profoundly impacted by that moment, recognizing the power of being trusted, not only as a physician, but also as a compassionate human being. Despite 100-hour work weeks, sleepless nights, overwhelming responsibility, I knew that family medicine was my calling, the place where my deep passion meets the world's deep need. It was an honor and a privilege to be invited into the most intimate moments in the lives of my patients. Yet physicians are no longer in charge of healthcare in America. I left my practice after a lawsuit during which I was told by the plaintiff's attorney, "This isn't about you, it's about money." Forbes' rating of America's most trusted professions ranks nurses, as usual, at #1, followed by physicians and pharmacists. Car salespeople are second from the bottom, and below them are members of Congress. Even in Nepal, as a medical student who did not speak the language, I had my relationship with the young patients and their parents. That made all the difference. Today in the US, patients and providers alike have been reduced to commodities. The doctor-patient relationship, the only truly essential element in healthcare delivery, has been undermined. The pandemic has simply helped reveal what has been true for decades. Our healthcare system has been shattered. And I will pass it on to Mary Pat.
Good morning, and I want to thank each and every one of you for being here today as we're describing shattered and what moral injury is. I've been a nurse for over 30 years, and I have worked across the lifespan from cradle to grave. I've worked in the neonatal intensive care unit, pediatric oncology, geriatrics, burn ICU, multiple intensive care units. I have been a traveling nurse, and currently I work in hospice, which is truly my love. I have a passion for individuals, for patients and their families, and I love the profession of nursing. Moral injury has taken its part amongst many of us, as you have heard. Yes, I have been bitten. I have been sent to the ER while I was working, secondary to injuries sustained at work. But I kept going. It's that resilience. I kept going. I chose this profession as a calling, I think, because of the hope and the healing that I wanted to provide for patients, families, and communities. But the hardest part is knowing that we know what we're supposed to do in caring for our patients, but many times we are not given the tools nor the support from the hospitals, long-term care facilities, assisted livings, home care companies. We're just not given that support or the tools, and we have to do without. It's been very difficult to constantly having to pick and choose because we are repeatedly expected to transgress our longstanding commitment to healing by making choices that we don't want to make. The constraints are too much, and the moral trauma, it affects our sense of what is right and what is wrong, because our hospitals and organizations and for-profits are really about profit. They're not about the patient. They've taken the care out of health. It's truly a model of sickness, a disease-focused model, not a patient-focused model. I'm also on faculty, and I teach our future nurses, our nursing students. And I've been to many, many clinical sites, hospitals, home care, nursing homes. And not too long ago, while I was visiting my patients who were hospice patients in an assisted living, family members weren't allowed to be there. And so as I walked into one facility and I'm taking care of one of my patients, and I know it's her time has come to leave this world as we know it. And I called her daughter in Florida to let her know, hey, it's Mary Pat, I'm here with your mom. And I just really want you to know that I think it's her time. I believe she's going to leave us very soon. And her daughter was in tears saying, I just really want to be there. Is there any way that I can see her? Any way at all? And I said, let me see if we can video. Let me see if we can do a video. And we did. I asked one of the caregivers to show me how, because I wasn't quite used to video conferencing with a patient and family member. And there I was with my cell phone, talking with her daughter, who's now talking with her mother, as her mother is dying before her. It's a tough thing to watch day in and day out, somebody die without their family member there. This wasn't my only patient who I had taken care of, whose family member wasn't allowed to be there as they were dying. That really tears at your heartstrings. And you sit here going, wow, here I am having to be a surrogate family member as I care for those whose family members can't be there. It's another level of stress, taking away that human interacting. So one day as I was heading down the mountain, a poem fell into my head. And the poem is, who will I sit with as they take their last breath and slip away? Who will I sit with today as they take their last breath and slip away? The lives they have shared, the stories they have told, these are the gifts that I behold. Who will I sit with today? Our system is shattered, y'all. We need your help. We need healthcare for all. We need your voice at the table. Thank you. And I pass it on to John.
Hello, y'all. Thanks for being here on a Saturday. And I hope that you will come away from this with some encouragement and even motivation to join this movement. I know I will. I just count today as a highlight to be able to sit on a panel with, as you can tell, so many caring, compassionate individuals that are providers. And thank you for this opportunity. I'm going to carry it forward myself and give more meaning to my own life. So my testimony about the problem is pretty brief because I've had plenty of time to boil it down or dumb it down, whatever. I'm a retired physician. I've had a successful practice, one that I feel that outcomes were good. And there was a certain amount of satisfaction, but there was always a nagging dissatisfaction that even if I was doing things right in terms of high-tech medicine and stenting and all those things, bad things, well, expensive things, that there was always this nagging uncertainty about doing the right thing. And it boiled down to, I wasn't able to see everybody. I wasn't able to see folks from all walks of life because of our system. And I had experienced that volunteering in multiple countries, South Africa, Brazil, Bhutan, Kenya, Thailand, where everybody came, either walking through the jungle or down the river in a boat, and they were not denied care. And it was some of the most satisfying part of my career as a physician, which has been denied in this country because of the system, which doesn't encourage or support that. So in my own small way, now that I'm retired, I want to make up for some of that dissatisfaction by giving back. And who I care for are the providers today and the young people coming along into the profession who need to know that this is indeed a noble profession. This is a profession that should be filled with joy and satisfaction, and that if we have the time, and I hope this is the venue to start to talk about some of these solutions, we can make a strong argument that universal health care is a major solution to the problem of prevention of disease, of health rather than wealth, of simplicity, and of interrupting this cycle of moral distress, injury, and suicide. 1 or 2 physicians a day committing suicide. And I'm happy to tell you that Thursday, the Senate, after 2 years, passed Senate Bill 610, the Lorna Breen Provider Protection Act, that will go to the president's desk for signature, maybe has today or yesterday or tomorrow. But that is an indication that people are responding, that the not just you trustworthy, compassionate providers, but the public, and even though the lower life folks who don't share some of these concerns, it's very encouraging. And I think it's because you're active, you express, you give your testimonies, you participate, and we encourage you to join us in this movement.
Thank you, John. Maddie, do you want to introduce the Q&A or should I?
Yeah, I'm happy to say that. So we do have other things to talk about, but we would like to have this be dynamic with our audience. And so first of all, Bill, do you have some questions in the chat? And if so, we can start talking about them, or we can start talking about some of the solutions.
Thanks, Maddie. In fact, I do not see any questions yet. I think that speaks both to the range and heartfelt, wonderful presentations that have been given, and to how the caring that's so clear gets squelched by how we pay for healthcare, leaves us speechless. And I think that's some of our challenge, is that what we need to do to some of us is so clear, and what we're up against seems so mammoth at times. We do have a question now from Joe Lewandowski. How long has the Massachusetts rule been in place for nursing staff, and what do you hear about how well it's working? I think that was Pennsylvania also, and Illinois had laws to control the nurse patient ratios. Does anyone have some feedback about how that's been working out?
I'm afraid I'm not aware of what the results of that have been. Is there anyone else on the panel who knows anything, or in the audience for that matter?
Lori.
I just remember when I was an intern in Spokane in 1985, the nurses were talking about nursing ratios. And as I went through my career, it got worse and worse and worse. And finally, as a doc in private practice, I recruited a nurse from the hospital who had been a hematology oncology kind of cancer nurse at the big hospital in town. And she said, I just couldn't keep going when I was assigned 7 patients on a shift. And they were dying patients and patients who needed their chemo on time, and I couldn't manage them all. So she quit the hospital and came to practice with me outpatient. So this is not a new problem. And I think we're fortunate that the pandemic has uncovered it. So I don't know about the results of the new laws, but I think we need to be careful to realize that hospitals have gotten away with this for 40 years. And just because it's just coming to our attention doesn't mean that it's okay. I mean, there needs to be wide sweeping addressing of provider trauma in order to go on caring for Americans.
So we have a question from Meg Weingerter, who is asking, given the difficulty of getting robust coverage changed, are there less ambitious measures than universal health care that would make a significant difference?
Take it away, Maddie.
Yeah, first of all, welcome. I really think that at this point, the problem with why nothing is being done is because the profiteers, who are the hospital corporations, insurance companies, and big pharma, don't want anything to be done. They're making a lot of money. They really made huge profits in the billions during the pandemic, and they don't want to lose that money. So unfortunately, they give huge amounts of money to the people who are supposedly representing us in state legislatures and Congress. And that's certainly one of the most recent examples of that is what just happened in California, where they had a single payer state-based law that had wide bipartisan public support, but was never introduced to the California state legislature because the insurance industry gave literally millions of dollars, including $1 million to Gavin Newsom for his campaign fund, and it was never even introduced. So I think that my feeling at this point is, number one, I don't think, because there's a basic flaw in the system that we have now, we need systemic change. And I don't think that the people currently in power who, I don't think they're Democrats and Republicans. I think that they are corporatists. They have no desire to make a change. So this is going to be a grassroots movement, just as the gay marriage and marijuana laws were from a groundswell of grassroots support. That's how those changed. On the other hand, there are things that we can be doing, such as what was in that video, which is there can be mandated nurse to patient ratios. But as they said in that video, it was squelched by the profiteers. They call themselves the Partnership for America's Healthcare Future. Well, I call them the partnership to protect our profits, because that's really what they are. And until there is a paradigm shift that healthcare, the purpose of a healthcare system is to keep people healthy, from the purpose of a healthcare system is to maximize the profits of a few, then the chance for any change is small. And all you have to do is look at what happened with the quote public option unquote, which wasn't a public option in the end, that we had in this state last year.
Do any of the other panelists want to say anything before Bill takes the next question on the same topic? Okay, take it away, Bill.
So maybe this leads to the next question is, what's morally lacking, if anything, in American culture that prevents our having universal health care like so many other countries do?
We don't care. We're individualists. We're all the big wild west, and don't even machine our own.
John Ward, your hand is up.
Oh, I feel like we are culturally less connected than we've ever been. Even though we have the internet and social media, we aren't sharing openly and honestly the basic needs that make us happy and satisfied. We're being pulled so many different directions. And part of it's historical, because we're an individualistic society and not a socially conscious society like Europe, being more so. But our values have become more selfish, in my opinion.
Thank you, John.
And maybe a piece that relates to this too is, and John, maybe you can speak to this. You brought up the Breen Act. What does that do?
Yes. Well, first of all, Lorna Breen was an ER physician in Manhattan who, in the beginning of the COVID times, she caught COVID, and it affected her physically and mentally, such that even though she tried to come back to work, because, well, it's complex, but physicians and nurses are frightened to admit to any deficiencies because we're not supposed to have any deficiencies, right? And so we can't accept any mental care or treatment because it would reflect poorly on our jobs, perhaps with the hospitals and whatnot. So in part, she didn't have access to mental care. She came apart with having to burned out with all the people she had to take care of, as well as herself becoming mentally dysfunctional, and she committed suicide. And unbeknownst to the people around her, it was too much. And her family stepped up to say, well, there's a reason she did this. She was a normal working mother who came apart from the stresses, the demands of the system, basically. And so we put together this, sponsored by the lead sponsor was Senator Kane from Virginia, put together a Provider Protection Act that would provide mental assistance to providers, as well as look into the causes of the problem in the first place, which is the more important part of it. Well, as important is to attack the underlying cause for this fragmented, stressful healthcare model that we have. So, and like I say, after 2 years, it passed all the committees and the Congress, and then Thursday, 2 days ago, the Senate, and now will go into effect, and it will provide at least 100, I can't remember exactly, maybe $200 million for studies and actions to help the providers keep working and to find solutions for the causes in the first place. And we have our own explanation of these causes, which we have a very strong argument for, but we can get into that if you so choose.
Thanks, John. Maddie, I see your hand is also up. We do have many
Yes.
questions coming, but it sounds like you want to say something. About
Yeah, I wanted to just address the question.
Uh-oh. Hold on, Maddie.
Maddie, you're muted.
Sorry about that. Yeah, I actually think that there is a systemic problem that predates COVID for what is going on here. And Warner Breen certainly showed that up in terms of systemic changes. It wasn't just about her being overwhelmed and not being able to access mental health. That was part of it, probably. But what is really going on here is a system which I think has been embedded in the American culture since day one, that there are human beings and then there are everyone else. And those are, originally it was white hetero males, and I know I probably sound like a crazy person, but just read the Declaration of Independence. The people who were considered human at that time were white male landowners, and everyone else was considered subhuman. And the system is set up to exploit those subhumans, even if they're just poor people or don't own land or whatever. And that is what our system continues to do. Right now, in the current day, what is happening is that the system is exploiting so-called healthcare providers, which is a business thing. We actually are healthcare professionals, and we consider it a noble calling. We are human beings. We are not assets. We are not commodities. And we have been trained on how to take care of our patients. However, we are forced to run up against the barricades of our healthcare system, which is, as was mentioned by our panel, to see as many patients as possible, as quickly as possible. Patients who are also considered commodities are told you can only bring one problem to your visit, so you better decide what that is, because that's all we're going to listen to. I know in a local hospital corporation clinic system where I am, if the doctor hasn't gotten done with their patient fast enough, someone comes and knocks on the door to get them moving forward. And that is a system that we're working under. It's about making the maximum profit. It's going on now with the direct contracting entities that they're trying to pull off, so that people going on to Medicare will unknowingly be put into a Medicare quote advantage plan, which I call disadvantage, in which they will have narrow provider networks. They will be fine as long as they don't get sick, after which they will be told that they have to pay a lot more for copays and deductibles than they would on traditional Medicare. And they aren't even being told this is being done to them. So they're trying to get away with that. It's a privatization of healthcare, just as there is privatization of schools and prisons and so on and so forth. It's an across the board cultural problem. And it may seem overwhelming, but we just have to change things one thing at a time.
Thank you, Maddie. Bill, if you don't mind, as a former reporter, knowing folks are on deadline and have to be somewhere, if it's okay, can we take Obed Manuel's question from Colorado Public Radio? And thank you to both you, Obed, and also Meg Wingirder from the Denver Post for being here. We really appreciate that. So his question is, has the health insurance system made burnout worse since COVID began in your experiences? And if so, how? Maddie and John. I'm gonna start with John and then Maddie.
Well, I've been impressed by how insurance companies directly have had a huge layer of stress to performing your work as a provider and dedicating your time to primary patient care rather than computer entries and billings and codings and things that the insurance companies require and reject and ask for more and more, until the computer system alone has driven a lot of healthcare providers out of the business. And it relates directly to insurance company demands.
Okay, thanks. And then Maddie and then Robin.
Yeah, just in answer to that, as I mentioned earlier, COVID exacerbated what was already a problem. It just exposed what was already going on. So, for example, the American Psychiatric Report that came out was in 2018. That predates COVID. I quote retired unquote from medicine in 2017 due to moral injury, which was before COVID. And really what's happened is that this is what the system is, and it was just exposed more clearly because of COVID. So yes, everything has gotten worse, but it was bad before that. And it's just showing the weaknesses of the current system.
Thanks, Maddie. Robin?
Thank you. I'll give a specific example of that regarding telehealth, because before COVID, I was not doing telehealth, and now about 50% of the time I engage with patients is through telehealth, primarily just over the phone. Insurance recently has been requiring or basically threatening that a telehealth visit will only be reimbursed if it's video, not if it's simply over the phone. And while yes, having a video telehealth visit can provide you with more information, especially if you're seeing, somebody has complaint of a rash, and you can have a little bit more of that context with the patient. It also limits like who can access telehealth, because that means that patient has to have access to Wi-Fi, to a smartphone, to technology that many patients don't have. And therefore, it makes our class system even worse. We already have this class system within healthcare, and it just amplifies that. And in my experience, you can provide great care by simply talking to a patient over the phone, especially mental health care, which we obviously need more and more of.
Thank you, Robin. Okay, Bill?
Yeah, here's a timely question based on the pulling of the AB 1400 bill in California. How does the grassroots activism compete with special interest millions? So many legislators campaign on single payer till they get to the state or federal level and are overcome by the lobbyists and the campaign funding by special interests. We get lost in the political process. This keeps feeling like a losing battle. Help. Who'd like to take that one on?
Okay, Maddie, I'll spotlight you.
I'd be happy to take it on. So, I mean, you're right. It can seem overwhelming and so on and so forth. Recently, Ralph Nader's podcast, and he had on a guy who's now making his living telling people how to deal with insurance bills, which is basically a full-time job. As many of you can attest, have had to deal with those. But what we can do, I have a little local story. I live in Southern Colorado in a rural district, and we have Black Hills Energy here, which, as you all may or may not know, is a local corporation who we have the most expensive electricity in the state of Colorado. And of course, they want to continue to raise our rates. So we had a bill up in Canyon City because they want to renew their charter. So immediately, Black Hills $400,000 campaign to have their new charter. I was in the group that was fighting them, and we raised about $5,000, and we won that vote by 2/3. So I'm not sure we can get much from our legislators, but you know, that's one reason why we talk about possible referred measures. But the other thing is, if we can get the grassroots to be talking to the people in power, and they can get the message that if they don't do what's good for the people, then they won't be in office anymore. And of course, that's how it's supposed to work. We live in a corporatocracy now, as I said, but that is the thing that we can be doing. Ralph Nader said to this guy who was not in support of single payer, well, you should read my book, Breaking Through Power. And so I did get that book and on a Libris, and I recommend everyone read that who feels overwhelmed, as many of us do.
Okay, thank you, Maddie. Lori.
So I think several of you have asked a question that is answered by the same thing. You know, what can we do, and what do grassroots have to do with it? And what is morally lacking in American culture? I think the answer is really, really simple. And my personal belief is that universal health care is the only answer. It's the answer that's working in the rest of the developed world, and much of the underdeveloped world is thriving with universal health care. In America, it's political will, it's the corporatocracy, it's the fact that our elected officials don't represent we the people. A large majority of Americans want single payer. The healthcare is their #1 issue. It's not even coming up, right? The issue is political will and bringing measures to the people, not running measures through legislatures that are influenced by lobbyists. It has to come from the people. When we tried to pass medical aid in dying in Colorado, it was rejected by the legislator twice in a row, came to the people, and 65% of Coloradans voted for medical aid in dying, and still Catholic healthcare is refusing to implement it, breaking the law in Colorado, refusing to implement the law that the people voted. So that's my perspective.
Thank you, Lori. Robin.
Thanks. Yeah, I just wanted to kind of piggyback on all of that and say being involved in this organization has really helped me, and actually helped me with moral injury and distress, because it's empowered me to, yes, this is a hard fought battle, and we've really been fighting for this for decades before I was, even involved in it. And we have a lot of money and power against this issue, but finding other like-minded people who still have passion for change, and also realizing like this is my way of promoting social justice, as Lori like alluded to, and Maddie too. It's like if we had single payer healthcare, we would have more opportunities for, like, people would be healthier, more engaged in society, our economy would improve, we'd have more entrepreneurs because people wouldn't stay in their jobs just for healthcare. I really feel like this is it's a huge issue, but it could make huge impact. So that helps keep me going.
I'm going to call on John. I really like that everybody's commenting on things. Just for everyone to know, we originally set the event from 11 to 12, but we also made it till 12:30, so we don't have to cut off any discussion. So we will go until 12:30. So hopefully there'll be a chance for the panel to take all the really good questions that are in the chat. Okay.
I'd just like to say a part of this is education, and it's a slow process getting people to understand that money's coming out of their pockets. And maybe if they saw that more directly would be one way to do this, but they're paying twice as much for less care than any advanced country in the world. And if we can educate like we did in Colorado with this study that Bill could expand on a little bit more, showing that quality healthcare can cost less, that we need to educate folks and hit them where their wallets are. I think that's something everybody understands.
Thanks, John. Maddie?
Yeah, I mean, we've been kind of skirting about this study that's just came out, which was met, as Bill says, the sound of crickets. And I think that we need to be letting, especially the press, know about the task force study that came out as a result of House Bill 19-1176. And what the study was done by the School of Public Health. They were hired on by the task force. And that report came out on September 1st and was distributed to all the legislators and the governor, and nobody said anything. There was a brief 15-minute testimony in a joint meeting of the health committees for the legislature, and that was it. And what that study showed is it compared what we have now with a multi-payer system like a public option versus single payer. And what it showed was that single payer not only would cover all Coloradans, but would save billions of dollars. And in addition to that, they looked at several social issues and how they would compare in those systems. And single payer improved multiple social issues, including decreasing unemployment. So especially for people who haven't read that report yet, there are links available on our website, and we need to be getting the word out about this. So our hope was that the legislature would at least look at this, and possibly we even wrote a draft of a possible bill that they could use. And there's absolutely no movement from the legislature, and we need that public pressure to get them moving on this.
Thank you, Maddie. Someone mentioned that many people on the call are activists. Do watch. We have an event coming up in March urging the legislature and Governor Polis to be bolder on healthcare before we keel over. So watch for that. It's likely to be March 18th. Bill, you have another question for us?
Yeah, and this is maybe more of a statement, but I think it raises questions. There's a lot of distrust of government that is understandable in some ways, but it's used by corporate interests who use it to undermine government doing good stuff. And meanwhile, at the same time, corporations use their interest and use government for their own purposes. So does anyone want to speak to our attitude towards government and how corporations use government both to put it down and to further their own interests.
Thank you, Bill. I'm going to call on Lori, whose hand is up.
In a word, I think the problem is disinformation. So from the beginning, the opposition to universal health care was, I don't want the government in charge of my health. They mess everything up. And that was the line that's been set out from the corporate profiteers from the beginning, right? So universal health care means the government pays for health care. The government is not providing health care. Universal health care means every single provider is available. There are no networks, there are no co-pays, drug costs would be managed. The government is simply providing protections for the American people. Protections for the American people are what corporate interests call regulations. You can't tell me what to do. You can't impede my ability to make a living. You can't. And so the whole point of grassroots and activism like this is getting the truth out there with all the disinformation that's on social media and in the mainstream media. All the promotion of Canadian disasters in healthcare. You don't want to go to Canada. Canadians wait in line and die while they're waiting in line for their surgery. That is all false. It's all false. So for us, someone in the chat talked about talking to their neighbors. Thank you. Talk to your neighbors, talk to your friends, find out the truth. We'll be having more webinars. We'll be talking about specifics of what's wrong. We'll be talking about nursing ratios. By the way, Katie, the nursing ratios, I think Mary Pat can speak more directly to this, but they depend on the acuity of care. So often in the ICU, the nursing ratios were 1-to-1. And if a patient was less acute, they might go to 1-to-2, one nurse to 2 patients. And on the ward, it might be 7 or 8 patients, but I don't know the updated actual numbers that Mary Pat might answer. So the point is all these little specifics, let's talk about the truth. And once the American people know the truth and not the disinformation, the answer is pretty simple.
Thank you, Lori. Mary Pat?
So in reference to nurse to patient ratio, currently it has been 1 to 2 patients in the ICU, depending upon acuity, and on a med surg for approximately 6 patients. But needless to say, what we currently have is California is truly the only state with a law that requires a set nurse to patient ratio. And that's about 1 to 5 on the med surg unit. And then it's based on acuity in the ICU. Massachusetts has passed a similar law, but their legislation only requires that nurse to patient ratios are in the ICU, and that's dependent upon the stability of the nurse. But it's really difficult in terms of the nurse to patient ratios because many hospitals really do not look at the acuity of the patients. So for an example, I was a traveling nurse in the state of California. I went to California simply to study the nurse to patient ratio that was mandated, I believe, in 2005, if memory serves me right. What you have to understand, coming from someone who's walking the walk, is that, yes, I was assigned 5 patients, but I had 3 LPNs. I had to do the LPN's assessments. I also had to hang their IVs and do other things that an LPN could not do, which increased my numbers. Also, what you have to understand is ancillary staff is taken away. So we really have to be cautious and careful when we're looking at ratios because patients are not numbers. And we as healthcare providers, nurses, physicians included, really need to look at the acuity and what is really safe on a unit. That's kind of where I come from. It's getting really out of control right now with the number of patients that nurses are having to take. In a psychiatric hospital here in Colorado, a nurse may have 16 patients that are acutely psychiatrically ill. In a long-term care facility, the numbers are unbelievable, what a nurse has to take care of, and also in our hospitals. So I think we really need a grassroots movement in terms of all of us looking at this together. Thank you.
Thanks, Mary Pat. Before I forget, we have another member of the media on this event, Dave Anderson, Boulder Weekly columnist, is with us, and he did excellent coverage of the study in a recent column, and it was great to see because there's been precious little media coverage, even though the study was the result of a bipartisan bill that passed the legislature, that the legislature ordered, etc. So, okay, thank you, Dave. Robin, and then John.
I just wanted to say that one thing we do have is opportunity, because we don't currently have a single payer healthcare system. So we can design it, we can make it even better than Canada and New Zealand or wherever you want to compare it to, you know. We have this amazing opportunity since we're basically starting from scratch. So that also lights me up, it gives me hope.
Thanks, Robin. John.
Well, just briefly, I wanted to go back to that question about trust in terms of your health care, because I think it's a vitally important concept. And in our U.S. government, God bless them, they have done a lot of wonderful things, and yet they're not allowed or cannot market themselves. So then you're left with, well, who are you going to trust? You're going to trust corporate bottom line, or are you going to trust the private, industry, or are you going to trust the government who you've elected and to represent you? And I think the government is the lesser of all those evils I've mentioned, whether it's private, corporate, or governmental.
Thanks, John. Maddie?
Yeah, thank you. I am very glad to see CPR here. You are the main way I get news. I belong to both CPR and KRCC, so thank you for being here. I happen to live in a very Republican county, so we're doing a lot of work in my local healthcare group about communication. And what Lori said about misinformation is really important. But the other thing to become aware of is the innate framing that our culture makes us think in. And there were two examples of this that I believe were both on NPR. And that was, first of all, in terms of the energy industry, the reporter, basically referred to the energy industry as how much energy we're burning. Well, we aren't burning energy if it's renewables. So that was one frame that I noticed. The other one was in terms of healthcare. And never do we talk about providing healthcare for people. We talk about providing health insurance. And that is really a corruption put upon us by the partnership. So it's something that I hope our reporters will become aware of and try to avoid. Thank you.
Lori.
One other thing I wanted to mention is the United States and New Zealand are the only two countries in the world that I'm aware of that allow direct-to-consumer advertising. And unfortunately, as you know, much of the direct-to-consumer advertising in the US is pharmaceuticals. And they're expensive, very specific, not always safe, not always effective pharmaceuticals, like for a certain type of breast cancer that nobody understands by the number that they give you on TV, right? CR2, receptor negative, positive, this. And then they say, ask your doctor. So our whole focus is on treating symptoms, taking a drug to treat a symptom. And as Robin said from the very beginning, we can do so much with prevention, with lifestyle change, with mental health support, with social support, with alleviating poverty, with getting some equity and justice for all Americans. We won't be sick. We won't be needing sick care. We will be thriving and healthy. So pay attention to what you hear on TV and think about, wow, what if people didn't even get cancer? They wouldn't need to ask their doctor about some wacko, crazy, expensive treatment.
Thank you, Lori. Maddie, your hand is up as well.
Yeah, I was just going to share with people a recent newsletter I got. It's called The Prudent Prescriber. It's put out by a pharmacist or a physician actually on the Western Slope. And the main thing that I noticed about this is he includes the cost of drugs in this country, which are way higher than anywhere else. And another bit the media tends to talk about is decreasing the cost of drugs. But, you know, how are we going to do that? And the way that they say we should do it is that the insurance company should cover it. But when you look at some of these prices, they're shocking. And let me just give you a couple of them. Symbicort, which is an old drug for asthma, 3 inhalers cost $1,322.16. Whereas if you bought it in Canada, it would be $325. Another drug, which is called Merbetrig, 3 months worth in this country costs $1,493, whereas in Canada they cost $250. Another drug, Advair Discus, also a very old drug, it's for asthma. In this country costs $1,188. In Canada costs $358. And it just goes on and on. And so when you actually start looking at these numbers, what possible excuse does Big Pharma have for charging these numbers? I mean, it's just insane. And for them to say that it's because of research, that's just a total lie, because most of the research is done by publicly funded, i.e. taxpayer funded labs around the country. And then they sell the rights to it to these pharmaceutical companies. So it's just so crooked that it's just astounding.
Okay, thank you, Maddie. Bill, I want to bring up another question in the chat.
Yeah, one of the other questions that's come up is, you know, what about the role of nonprofits? If we take the profit motive out, doesn't that make things work well? You know, so there are nonprofit hospitals, there are nonprofit, not-for-profit insurance companies. Kaiser is a good example. It does, you know, it's conflict of interest, but it does both. What about the roles of nonprofits? Is that a way for us to go? And can we get some reassurance from that?
Okay. Thanks, Bill. Maddie?
Yeah, I'd love to. I personally think nonprofit is a term to save money on taxes. Because in my experience, for quote, nonprofit hospitals or working in nonprofit hospitals, they are very profit motivated. And they tend to spend money on public image, what I call fluff, rather than on patient care. So for me, I think that nonprofits a lie. A lot of these organizations may be nonprofit for tax purposes, but they definitely like their profits and pay their CEOs and other executives a large amount of money and are not putting that money into patient care.
Okay, and Lori? Thanks, Maddie.
So I actually read that question with a different viewpoint. I completely agree with Maddie about nonprofit hospitals, but I read sort of the grassroots nonprofit in that question. And I think my frustration forever has been, why are nonprofits struggling to raise money, not able to pay their employees well, not able to buy health insurance for their employees, when the government is not providing the social safety net, the equity, the justice, education. I mean, our whole structure of our society and the threat to our democracy that that no longer leaves we the people, or doesn't allow we the people to be what the government's all about. So in my sense, I'm not saying this very clearly. What I'm trying to say is, why are the nonprofits trying to take care of we the people? Why isn't the government there to provide the equity and justice and that we all need? So I think nonprofits are footing a lot of the bill for saving America, but in my opinion, that's morally unjust.
Thank you, Lori. Another question, Bill?
Yeah, let's go to this one of looking at the majority of Americans think that we have the best healthcare that the world has to offer. And as we've heard today, that's a huge untruth. How can we use that to help people to give up on what we have and move to something much better?
Maddie?
I think a lot of this is misinformation that we are struggling to expose. For those of, especially someone like John, who's actually worked in other countries, you can see that our healthcare system is not the best in the world. Many other healthcare systems are far better. From my own personal experience, we have a genetic problem in our family that increases our risk of cancer for some of us. And so one of my siblings required a bone marrow transplant a few years ago. And in order to be able to be a possible donor, we had to make sure we did not have that mutation. So I happened to have family at that time in Australia, Canada, England, and Israel. And so all the people in our family went to their family doctors in their various countries, and their doctors ordered the tests, and all of them, except me, had their tests back within a month. For me, it took 7 months of fighting with my health insurance company to get it covered before I could finally get it done. And by then, it was already moot. So, that is the kind of healthcare we get in this country. The goal of our healthcare in this country is to not pay for it. In fact, I met a computer programmer in 2017, when I was in Washington. I went to Corey Gardner's Colorado Coffee, and this young man was there who wrote software for Blue Cross Blue Shield. And part of his program was to automatically deny claims without even looking at them. And that right there tells you what the goal of insurance companies in this country is to deny care first up so that they can maximize profits. And that is what we experience in this country. And as a result, people in this country are dying in very high numbers of treatable disease. And in fact, that is what our event next month will be about, Be Bolder Before We Kill Over. It's the 3,500 Coloradans who die from treatable disease, not COVID. This has been going on for years, who didn't have to die if they could have had access to healthcare.
Thank you, Maddie. John?
Well, if I understood Bill's question correctly, I think quite simply and yet very complicated would be what we talked about earlier. And it's going to require a shift in our culture from individualists to community-minded folks. And what's the payoff? What's the stimulus to do that? Where do you find your happiness and satisfaction in life? If you dig deep, it's connection. It's connection with people. And we lack that.
Absolutely.
Thank you, John. Lori?
I wanted to mention, Maddie talked about denying care, and don't think this is a new issue, and it's not related to COVID. When I was a young doc, I was doing a circumcision in the newborn nursery next to an old pediatrician who actually had quite a tremor. It was amazing to watch him do a circumcision with his tremor, but he had trained me when I was a resident, and I really respected him. And he was telling me about a kid with meningitis that he had in the hospital right then. And back in those days, we kept kids in the hospital on IV antibiotics for 7 to 10 days for their meningitis. And he had gotten a call from a young woman. He said she sounded like she was in high school, from the insurance company, who told him he had 3 days approved for this child with meningitis. That was back in the probably early 90s. This is not new. It's just that they've gained so much traction and so much profit and so much power over our governmental protections that we don't have a choice but to go to universal health care.
Yeah, I know I'm not supposed to talk, but I did billing for my, at least not much. I did billing for my father, who was a psychiatrist, in the year between high school and college, which, to date myself, was 1989. And right before, just as managed care was starting, and it started in mental health and then has spread like cancer across the healthcare system, the insurance companies dictating what can and can't happen to the providers. But that was part of my job, was to take each claim that was denied and go back and forth with the insurance companies multiple times. And it was like playing Nancy Drew. I had to keep notes on every single one, you know, and every like $90 payment that came through had like, you know, sheets of and that was already back then. So just, yeah. And we've got about 7 more minutes left. Bill, let's
Well, I'm not seeing any, I mean, I think we've covered the ground so well. I'm not seeing other questions that we haven't addressed, but I wonder if we just want to leave it open to our presenters to give some final thoughts, of things that that this has stirred up for them.
That's a good idea. Mary Pat's hand is up. So let's start with you, Mary Pat. Oh, I got to ask you to unmute.
There. I just want to make a brief comment. I believe Les posted this in the chat. Yes, Washington State did last weekend, I believe it was on the 13th, did pass House Bill number 1868 for the nurse to patient ratio.
Great. Wonderful. Okay. John? And then
Just a final comment about, if you want happiness or joy or meaning or purpose in your life, then help your community, help your society, and drop some of your own individualistic, selfish desires to own everything possible and be wealthy and powerful. Amen. Sorry, had to say it.
Okay, thanks, John. So then Maddie, and then
I want to go next after John just said that. Excuse me for interrupting.
That's okay.
I was just going to say, those of you on this call, I think, are already on board with helping your community. And I just wanted to say, join us. Thank you for being here. Come back for our other webinars and join medical professionals for universal healthcare.
couniversalhealth.org.
All right, so Mary Pat, is your hand up again, or is it, did I just not lower it? And then
I just want to, it's up again.
And then
I think Maddie was first.
Well, Robin hasn't spoken yet, so technically she's next.
All right, so let Robin go.
Okay, all right.
Yeah, I'll just reiterate, thanks for everyone who helped organize this, who's here. Thanks to the media for being here, and hopefully this will shine a brighter light on a more hopeful future where universal health care is a reality and we have improved social justice for all.
Thank you, Robin. Okay, so Maddie and then Mary Pat again. Does that work? I hope that works.
Yeah, again, I just want to thank everyone for coming to this. This is a heartbreaking issue. Unfortunately, we continue to have to deal with it every day. We're dealing with it in my family. We actually had another physician who was going to be on the panel, but she is dealing with moral injury and the cheating of reimbursement companies, and is overwhelmed, so she couldn't make it. So this is something that's happening every day. We see it in the news. We see it with nurses trying to stand up and take care of patients. For example, if the hospital is trying to get a union in Longmont. It's just happening all around us. It's been going on for years and it's just getting worse and worse and worse. So anyone who can help us, thank you, thank you, thank you. We've been working on this since Truman in this country. So we love your help. Thank you.
Thank you, Maddie.
And I too just want to say thank you to each and every one of you, and just reach out, touch someone, be there for your loved ones, for your community. Reach out to any of us that can be there for you and join us. I mean, truly, I'm learning day by day. I just learned yesterday of another colleague that completed suicide with a gunshot wound to her head. And it's been really sad in terms of the number of deaths that we're experiencing amongst our colleagues. So I really say, reach out. We're here for you. Thank you.
Yeah. Thank you, everyone. I think I could unmute everyone if anybody wants to just wave and say hi. I'm just going to go to the remove Mary Pat spotlight, go to the gallery view, something I've been wanting to do the whole time.
Take my hand down.
What? Yeah.
I just had.
Thank you so much for everyone who spent part of their Saturday collaborating for the good of all. And, we appreciate you. Keep up the great.
Thanks for your great questions, everyone.
Thank you, everybody.
Thank you.
Thanks,
Have a good
all.
rest of your Saturdays. Bye for now.
Be well.
Thank you all.